This week, we conclude our discussions on the demand of healthcare, and the topic is moral hazard. And we've discussed a high level moral hazard, but it's the tendency for behavior to change with the presence of insurance. The textbook calls it moral hazard is a tendency for insurance against loss to reduce incentives to prevent or minimize the cost of the loss. So basically, what that means is we talked about this. If I have car insurance, I drive faster. If I don't have car insurance, I drive slower. The presence of insurance changes my behavior so that I'm less careful because I don't mind if there is a loss because I know insurance will cover it. Moral hazard is probably the biggest concern we have with the Medicare for All bill. You're going to cover everything, give everyone full coverage. What's that going to do to demand, right? If we're covering everything, demand will increase. And the reason why we call it moral hazard is because we're trying to distinguish between natural hazards. So natural hazards, earthquakes, lightning, things that you can't prevent, versus moral hazard is carelessness or fraud that can lead to losses. So this is something that's particularly human behavior. Moral hazard with health insurance. So insured people take risks with their health that similarly uninsured people would not take, which is the general premise of it. And moral hazard is the downside of health insurance because it raises society's level for healthcare expenditures. So you saw this with the Affordable Care Act when we increased Medicaid expansion and when we provided low-cost insurance. People bought it, and when they bought it, they used it, right? You saw it also in the RAND study. People who had smaller deductibles, they increased their usage, and it didn't mean that their healthcare was actually better. So you increased costs, but you didn't actually change outcomes. So the moral hazard pattern, you'll see individual faces some risk of a bad event. We talked about how they look at risk. So this is taking into consideration the consumer's risk, and it can increase or decrease the likelihood of that event. They hold an insurance contract. Now you have to understand whether the insurance contract is full or partial. If it's partial, it changes their behavior versus if it's full. And then the price distortion is key. So the insurance distorts the price, and it's the reason why the price looks lower. Once the price looks lower, demand's going to go up, right? So in response to the price distortion of the presence of insurance, they change their behavior in a way that increases the chance of X or increases the cost of recovering from X. And the insurance companies can't observe this change. So this is a form of information asymmetry, but on the consumer side. A lot of the discussions we had in class was information asymmetry because the provider knows more. This, from the consumer side, the consumer knows more, meaning there's no way for Empire Blue Cross Blue Shield to know that that member with that insurance contract is going to take riskier steps or change their behavior because of the presence of the health insurance contract. That riskier behavior leads to a social loss. We'll describe social loss. In Medicare for All, we have to consider the impact of the social loss. We'll discuss it in future slides. So when we talk about moral hazard, you break it down into two different pieces, right? And this is key. Ex ante moral hazard, behavior changes that occur before the insured event, leaving a stove on, skipping the flu vaccine. So this is before I actually have the loss, my behavior changes. So skipping the flu vaccine is, I feel healthy, I'm not going to get the flu vaccine. I didn't get sick, but I took a risky behavior. That's what that basically means. The house didn't burn down. I left the stove on, but the loss didn't happen. So ex ante, always think of ex ante is before the event, where ex post is the exact opposite. Behavior changes that occurs after the insured event happens and makes recovery from that event more expensive. So this is after I get sick, right? Then I decide to get insurance, okay? Or this is after the knee hurts, I decide, let me get the replacement surgery instead of taking painkillers. So this is post the event occurring, and this is a lot of what the pre-existing conditions were all about. The thought process was, we need them to buy insurance before they get sick. And that's also the issue for Medicare, why they have such a short window to enroll. And that's the intention of open enrollment periods. That's why we want you to select your benefits for one time, select then, right? Whether you're going to have, so we're pushing ex ante moral hazard versus post moral hazard, ex post moral hazard, because we're saying make your behavior change about you're preventing uncertain risk before you actually have that intention and before you have that event. And the key is if we can get them to buy insurance before the event, then we have those premium dollars to offset what may happen when that event occurs. And so this is the real crux of the conversation. How does moral hazard lead to social loss? So the example that they use in the textbook is the cheeseburgers, but the basic premise is if I am diverting resources from the health economy to take care of somebody who has become sick or had a loss due to behavior changes, then I'm sucking and using critical resources from the health economy that in all else circumstances should have been moved someplace else, right? That's the key premise of it and why it's a social loss, because society gets hurt from this person's individual behavior change. So the cheeseburger example is without health insurance, the cost for each cheeseburger includes both the price of the burger and the increased chance of the heart attack. So I don't have health insurance, and so the cost of the cheeseburger is more money because I'm going to keep eating cheeseburgers. I'm going to keep getting high cholesterol. I'm going to lead myself to a heart attack, and now I'm going to have to pay for the heart attack out of pocket plus the extra cheeseburgers I ate. Versus the person with health insurance, the cost of the cheeseburger declines because the insurance company is going to pick up the price of the heart attack. And even if they have a deductible, $1,000, $2,000, it's going to be nowhere near the expensive amount of the full-throated heart attack, even discharge and treatment after the surgery. So in this case, social loss takes the form of extra money, labor, time, and effort that others expend on care for heart attacks caused by cheeseburger overconsumption. So you can think about the moral hazard that we saw in the RAND study, which it wasn't discussed when we talked about it earlier in the semester. The people who are going to the doctor because they have insurance, not because they're sick, but just because they have insurance, and so they're changing their behavior because now things are covered. That is a social loss because those doctors are diverting care from people who need it to care that doesn't need it. And that's where you see the health outcomes that didn't change even though people increased their utilization. That's a social loss. So Medicare for all, we do have to figure out how to eliminate the social loss, something that you don't see discussed on the news when politicians are talking about that plan. So we try to categorize a social loss using a demand curve, right? So remember, demand curve is price is vertical, quantity is horizontal, right? You see the D coming down, C is for consumption, and then point B versus point A. So when I read this, what I'm saying is PU, price uninsured, the cost is more expensive. Point A is a socially efficient equilibrium, or point B is the outcome with insurance. So PU, the price when I'm uninsured, that price is more expensive because every cheeseburger means I also have to pay for that heart attack, right? And so the price is high, I consume QU. So since I know that I'm going to have to pay for my heart attack out of pocket, and I know that I'm going to get sick and I don't have insurance, then the cheeseburger costs to me way more money, which means my consumption of it is lower because I have an expected loss that's greater, right? So my price is higher when I'm uninsured for that cheeseburger. Because my price is high, quantity is lower. QU is the quantity I'm taking when I'm uninsured. Now, what happens when I have insurance? This graph is trying to articulate the behavior change. When I have insurance, the price distortion starts to happen. The price looks much cheaper because now the heart attack cost goes away. Empire Blue Cross Blue Shield picks up the heart attack cost. Because the price looks cheaper, because I'm not going to expend all that money, now my quantity goes up because when price goes down, quantity goes up, right? So this is what we're trying to prevent. When Medicare for All lowers the price, PU to PI, right? And think about what our biggest issue is, which we heard from our last case study, obesity. So giving people Medicare for All potentially could lead to folks' consumption because we're changing the price of cheeseburger from PU to PI. Once I have price insured lower, my quantity goes from QU to QI. I want more. And so when I draw this line from point A to point B, I understand the social loss. By getting insurance, behavior changed so much so that my demand for cheeseburgers went up. It went up so much so that resources in the health economy is going to now have to take care of me when in a perfect world they wouldn't because of PU, the real price, right? But now they are. So I'm diverting that spending and those costs to someplace else. And that's the loss. That's the inefficiency in the market. And that's what this is trying to describe. The vertical distance between PU and P1 shows the extent of the price distortion. So greater distortion is done when you have fuller insurance. Remember, we have partial insurance versus full insurance. If I have a 95% co-insurance plan that 95% is being paid out of pocket, my PU to PI is going to be a greater distortion versus I have a high deductible plan. So that's the whole reason why we want to have a high deductible plan, because I'm trying to shrink the distortion. The one way to shrink moral hazard is to shrink the price distortion. The angle between the demand curve DC and the vertical represents the extent of the price sensitivity. So we talked about elasticity. How price sensitive is the market? So this PU versus PI could be a $5 burger versus a $15 burger, right? The degree and the slant of my slope, the slope of my line will tell me how price sensitive is the population, the consumer, to the social loss. So the heart attack is very expensive. And so when I have insurance, because I remove a lot of that extra cost, then there's a big distortion. I'm going to eat way more burgers. There's going to be a bigger sensitivity between price. So think about the slope, tells you how sensitive is the consumer to the price. And based on that sensitivity, you'll know how much quantity will grow when the price goes down. For every dollar in price distortion, you want to count the volume, the quantity change in the consumption of the burgers, right? And so this example, you have A versus B. All that it's showing is look at this slope of the line, right? Greater price sensitivity, because you can see the slope is closer to a straight line, and the price distortion is greater. So in figure A, price distortion is greater because there's a bigger space between PI and PU. So this means when I'm uninsured, I'm going to have a very big loss. This is like a catastrophic surgery. This is cancer. This is very expensive. But when I have insurance, I'm removing a very expensive potential loss. So insurance, so this is like protecting me from something extremely expensive. Call it hip replacement, heart transplant, something excessive, right? And that's why you'll see things like, well, let's increase the price of cigarettes because cigarettes leads to sickness. If I can increase the price of cigarettes, I can close the distortion. That's why cigarettes are so expensive, because the intention is to close the distortion of the moral hazard. People who have insurance still are less likely to smoke because the price of cigarettes are so much more expensive than it actually takes to create them. They added that tax to decrease the price distortion, to decrease the moral hazard. That's what that's showing here in A. Now, when you look at B, it's very different. Price distortion is very limited. It's not as big as uninsured versus PI, right? There's less distortion. And so price sensitivity is also more narrow. The line, the slope of the line is closer to a vertical line, which means there's no change. Inelasticity, right? No change in price. Less sensitivity means the price, and less price distortion means with insurance, I'm still not going to have as much. So in figure B, price distortion and price sensitivity are minimal. Insured individuals bear most of the cost of their cheeseburgers, and the demand for cheeseburgers is not very sensitive to price anyway. In this case, there's still more hazard, but it produces a smaller loss. And so in that instance, to having the insurance versus not having it doesn't change the behavior as much. And that's what you're trying to get to. You're trying to figure out where there's less distortion and less price sensitivity. And that's the key to taking out social loss. When you remove social loss, you have more efficiency in the market and prices stay down. So what determines the level of price distortion and price sensitivity? The extent of price distortion is a function of the completeness of the insurance, which we talked about. Fuller insurance, greater the price distortion. So that is actually a proponent for deductibles, right? This gets back to we need deductibles because deductibles eliminates the price distortion, eliminates moral hazard. The extent of the price sensitivity depends mostly on the nature of the risk being insured and how controllable it is, right? So some things are controllable. heart attacks, potentially the behavior, right? Some things aren't controllable where it's an inherent disease to your genetics. Or if it's not that controllable, then the price sensitivity is not that big. So you have to understand what you're actually talking about to understand the price sensitivity. So moral hazard, again, the asymmetric information in this piece, when we talk about this, is on the consumer side. The consumer knows that their behavior is changing, and they don't tell the health insurer that they are being more risky, right? When someone has Geico insurance and they buy a car, they don't say, guess what, Geico, now I'm going to speed all the time because I have insurance, and I have full insurance. I don't even have a deductible, so I'm going to speed. If I get into an accident, who cares? I got insurance. That doesn't happen. They don't call Geico and say they're going to speed. In the same vein, consumers don't call their health insurer and say, I'm going to get the best doctor, I'm going to get the best surgeon, I'm going to get the most expensive drug, brand name drugs. They don't say that. So the asymmetric information is the consumer knows more than the health plan. There's price distortion in insurance markets because insurance companies can't monitor everything the patients do and price their actions accordingly, right? And so the key here, moral hazard occurs if and only if three conditions hold. One, the cost of a risky or wasteful action to an individual is reduced, usually as a consequence of insurance, right? So insurance has to be full enough to reduce the cost of risky behavior. So that means I'm going to be more risky because the consequences are less. Has to happen. Two, there has to be asymmetric information that it prevents the insurer now from adequately pricing the action. Because if I knew the behavior is going to change, I would just put it in insurance premium. And I'd say, I know behavior is going to change, so I'm going to add it to my insurance premium. So when they pay the money for that insurance policy, I would offset the price distortion because it's inside the premium. But because this is asymmetric information, I don't know this is occurring. And then three, the individual responds to that price distortion by changing their behavior. There has to be a change in behavior for moral hazard to exist, either by taking more risks or demanding more covered goods and services. And this is important. Moral hazard can be taking more risks. So I act different because I have insurance, but it also includes demanding more covered goods. So think about this. If you have a high deductible plan and you know you're getting close to December and your deductible resets back to zero on January 1st, what happens? People demand more services in the fourth quarter. We see it all the time. It skyrockets. They're like, let me use my FSA dollars. Let me use my HSA dollars. Let me use my HRA dollars. Let me go to the doctor quickly now before my deductible goes back to zero. So that's an example of moral hazard, not because they're more risky, but they're demanding more goods and services from their health plan before it resets. Another example of moral hazard, that's not behavior change because of risk. It's just, I want to get the most of my health insurance policy. They're actually trying to make their partial insurance policy more full. They're using it to the capacity. So a couple ways to limit moral hazard, and now you'll know why health insurers do what they do. The entire construct of a health insurance company is to prevent moral hazard. So what do? They add the coinsurance, add the co-payments, add the deductibles, and add the monitoring. This gets back to RAND, full circle. Why do we have deductible plans? Why do we have coinsurance? It's too confusing. Why do we have co-payments? The whole reason why we have it is to reduce moral hazard. So if Medicaid for All is going to give everything to everybody for a very small co-payment or free, we have to think about moral hazard. We have to. The extent of moral hazard depends on both how sensitive demand is to price and the amount of price distortion caused by insurance. Insurers cannot alter consumers' price sensitivity, right? But they do have ways to reduce the price distortion. So all these things, coinsurance, co-payment, deductibles, monitoring, are all done to reduce the price distortion. You're trying to make the price that the member pays as real as possible. Remove the distortion. So, because when it looks cheaper, people will ask for more, right? So cost sharing, co-insurance and co-payments, 2 insurance contracts. Many of this you guys know. I won't go through it, but co-insurance, you pay a percentage of each bill. Co-payment, you pay a fixed dollar for each bill. Your copay. So every time a claim comes in, I pay $25. That's copay. Every time a claim comes in, I pay 10%. That's coinsurance. Because I have skin in the game and I'm paying money out of pocket, the thought is my behavior changes. If my behavior changes because I'm paying a copay, I've decreased price distortion. And so what does this look like? Full insurance without insurance, the individual would consume at point QU. So U is uninsured. They only consume at QU. You saw this in RAND. So these are charts to show you economically what's happening in the RAND study, right? And then at QA, it's very different. His effective demand curve is DF, and he consumes at QA. So quantity, it increases as I get insurance. So you see at U, my price is very high, and I only take quantity U. Quantity U is how much I consume when I'm uninsured, compared to quantity A when I have full insurance and I want more, so I consume way more at QA. And in DF, literally is a demand curve vertical because I'm inelastic. It doesn't matter what the price is because I have full insurance. DF technically could be argued as Medicare for all. People pay $0 out of pocket, everything is free. I'm inelastic to price. Doesn't matter how much the heart attack costs, how much the hip replacement costs, I'm going to get it because I pay nothing out of pocket. So look at my quantity. My quantity goes all the way to the other side. This is what we're trying to control. So coinsurance and copayments are trying to find a way to take that demand curve from being vertical and moving it horizontally, but not so much that you're uninsured. There has to be something in the middle. So what coinsurance does is it moves the demand curve from vertical over, right? Imagine the consumer starts at 0% coinsurance, full insurance. His insurance then increases to a level of coinsurance. As the coinsurance rises, they pay more money out of pocket. I shrink the price distortion, and then I move my demand curve over. And so what's happening is I'm getting closer to U. And you can see the social loss between when they're at U versus when they're at C. And C is with the coinsurance. Alternatively, imagine if he has a copay. So the copay, remember QA was when they had full insurance? All the copay does is move the vertical line over, and it moves them back because now I'm paying a $25 copay. So my quantity goes from quantity A when I had no copay and I want a lot to quantity B. It's in between QU, it's in between QA, quantity B, but it's still vertical because now the inelasticity occurs. Everything above the copay is inelastic. So I have a surgery, it's $20,000, $25 copay. So after 25 bucks, I'm inelastic, right? Coinsurance still keeps a demand curve because as the dollars get higher, the coinsurance payout is higher. Copay stays flat because as the costs get higher, the copay stays the same. So I'm not changing the price sensitivity. All I'm doing is moving back the vertical line with the copayment, if that makes sense. Deductibles. In addition to coinsurance and co payments, many insurers include a deductible, just like car insurance. You pay a flat dollar upfront before the health plan kicks in. Just another way to reduce price distortion. And so you can see what happens here. When you're in the deductible region, M1, you're paying full. Then you have coinsurance, you're paying 33%. Then you reach a certain amount, and then you pay zero at the catastrophic size. This is how a lot of the high deductible plans are structured. You pay out of pocket a certain amount. Once that happens, then you share with the health plan up to a certain amount. And once that amount happens, then the health plan covers everything in full. All of that is created to lower the price distortion and change behavior. And the thought process is once you get to catastrophic, it's not like something you can change with behavior. It's not like you're going to make yourself go in for surgery. So you try to have the deductible region on the front end for the low cost items. The cheaper items that are more done through cosmetic or through choice. And this also is a way to push back on physician-induced demand. Now that I have $1,000 deductible, when the doctor's like, you need 5 tests, I'm going to think before I take those 5 tests. I'm impacting physician agency with my deductible because I'm making now the consumer think about, do I need those 5 tests? And ask more questions and probe because the money comes out of pocket. So they're thinking more about it. So here with the deductible, it's like a step, right? With coinsurance, we move the demand curve. With copays, we shift the vertical demand curve. With a high deductible plan, you can see that when I have the deductibles, like I'm uninsured. So when I'm uninsured, I get at QU. But then when I have the deductible after I hit it, it's like I'm full insurance. So then I get at QB. And so you can see the change happens when the deductible is over. So it's like I'm uninsured, but then I'm not uninsured. I'm full insurance. That's what a deductible does. And even with the deductibles low, moral hazard could still persist because it's basically saying if I have a $200 deductible, I may blow through it because I know I'm going to get full insurance after the fact. And so the social loss in B with the low deductible plan is actually greater than the social loss in A because the deductible plan is so high, it's like I'm uninsured for a short duration until I get to a point where I have full insurance and then my quantity increases. And then lastly is monitoring. So some insurance companies try to observe and guide preventive measures. So this is monitoring, we call it gatekeeper. Gatekeeper is referrals. The only way I can see if what you're going to the doctor for is for something reasonable, usury and customary, is by saying, I'm going to mandate a referral. So a referral is going to basically dictate when you can see a specialist. That's one way of monitoring. Another way is pre-authorization. Oh, you want to have surgery? Oh, you want to get a mammogram? Oh, you want an MRI? That needs to be a pre-authorized service. You can't just go get it yourself. The doctor has to submit something to me, justify that it's important, and then I can let it go. These are monitoring systems that they have. We also have employee incentive programs. So at Empire, we pay for people to go to the gym. This is incentive programs that say, I'm going to pay you to go to the gym. And here's what's the reverse is happening. The gym looks cheaper. So if the gym looks cheaper, I'm going to motivate behavior for you to go to the gym. This is something where we pay $400 a month up to someone's gym membership for them to go, because the likelihood that they use it means that technically they should be healthy in the back end. So these are monitoring things that happen, pre-authorization, gatekeeper, so requiring a referral, requiring that you have to see a PCP before you go to a specialist, and incentive programs. A lot of employers are looking at incentive programs, changing the behavior of their employee population through incentives. And all the incentives are doing is limiting the price distortion for something else, for something healthy, right? So evidence of moral hazard, it's empirical, a lot of research studies there. There's a video that I uploaded in YouTube where you can read in more layman's terms the behavior change. And so it's interesting to see the studies that are out there on behavior changes within healthcare. And then the RAND is a huge one, right? People on the free plan are more likely to show up at the hospital with broken bones and drug abuse than people on the high deductible plan. So it just tells you that when it's lower, we've distorted insurance 100%. And so people are going to use it. The quantity grows massively. There's other examples here. RAND is the key one. I think it's good to, you explain RAND in one way in common sense and it makes sense. And then this chapter is trying to explain the economic principles and the charts that go with the RAND study so you can put the two and two together. And then we can talk about private versus public markets for insurance. Private markets can navigate the trade-off between moral hazard and uninsured to provide optimal contracts. What that means is I can see what people do in the uninsured market and use that to measure how much behavior change is needed. So basically at Empire Blue Cross Blue Shield, I'm able to measure how much behavior changes between a $25 copay and a $30 copay. $5 change in copay, how much do I change the price distortion? So how much does the behavior change? But public insurance, and this gets back to Medicare for All, is much harder because public insurance is necessarily non-voluntary government-provided insurance. It lacks self-corrective features that makes national insurance policy both complex and more critical. So what this is speaking to is the issue we have around Obamacare, the Affordable Care Act, and also what we will have if we try to build a Medicare for All policy. Public insurance doesn't have uninsured populations, right? They do, but they're not supposed to in theory. Everyone over 65 is supposed to have Medicare. Everyone who makes less than $15,000 a year or $16,000 a year who's a U.S. citizen is supposed to have Medicaid. People who are uninsured is because they're eligible but have not enrolled. And so it's much harder to understand their behavior changes when they're eligible and have not enrolled, because if they have not enrolled, it's because they don't need it, so they're most likely to be healthy, than it is in the private market. and to also reduce the price distortion is much harder because it's free. And so there's been conversations, especially under the current Trump administration, of putting copays in Medicaid. And the theory behind putting minimal copays in Medicaid is to try to prevent this moral hazard. And it's something to think about. Do you need copays in public insurance that's free? Because how do you stop the moral hazard? Is there a way? Or is there a way to stop moral hazard on the provider side? Because think about what moral hazard does to the provider side. If you already have physician-induced demand, and you already have physician agency and monopoly rents, if you add on top of it demand from the consumers, you just exploded the health insurance market. So in conclusion, understanding moral hazard is critical to understanding how health insurance works. Every insurance scheme must cope with this problem, including ours. Insurance plans in real markets are always necessary, incomplete because of moral hazard. The consumers know more than the health plan. So I never really price appropriately for behavior changes when someone has insurance. The adoption of new technologies by providers poses a particular challenge since untried and expensive technologies create more opportunity for moral hazard to increase healthcare expenditures, which we talked about the medical arms race. So if healthcare is cheaper, it literally incentivizes providers to charge more money because the price distortion gets greater. If it's free, you can charge whatever you want. No one's going to look at it. It's kind of like a hotel. If you get a free stay at a hotel, you're not going to look at the bill, right? Because it's free. But if you're paying for that hotel room, you're going to check every single thing. Who took something from the bar? Who took something from the snack bar? Who ordered a movie? You're going to check everything because it's on your dime versus when it's not. And that's exactly why health plans send explanation of benefits. The hope is you open up the mail and you read what they send and you look at it and say, I didn't get that service. How come they charged me for that? Even if it was covered in your copay, it's another way for monitoring to show someone, hey, if you saw something that you didn't get, please call us back so we can reduce the cost. Because it is incentivizing providers to add costs in when there's lots of price distortion in the market. So that was quick on moral hazard, and it's an important concept, very critical to figuring out Medicare for all.